Welcome all to our class. So today's presentation is about ectopic pregnancy, abortion, NICE guidelines, GTG we are going to cover. So welcome to the class. We start with our tagline, that is master MRCOG with concept oriented clarity. This is the most important thing because if you want to clear your MRCOG, you need to have your concepts which are very, very clear. Okay. So whenever you finish your module, try to solve the SBAs because finally your score matters a lot. So we begin with this short introduction and start with our GTG on diagnosis and management of ectopic pregnancy. So as usual, in the GTG, they give you the recommendations which are given in the bold letters, and those sentences are going to be very, very important, and most of the SBAs and EMQs are asked from there. Okay, but detailed guideline you have to read. So what does this guideline say? Incidence is approximately 11 per 1000. Okay, so this particular figure, 11 per 1000 pregnancies, you should remember because this is an SBA. So it comes as a 1.1%. It may come as a 11 per 1000. So please make a note in your numerical page that ectopic pregnancy prevalence is 1.1% or 11 per 1000. Okay. Now the incidence of ectopic pregnancy in women attending early pregnancy unit is 2 to 3%. Okay. So please remember, if you are asked about the incidence of ectopic in general population, it will be 11 per 1000. But if it is in early pregnancy unit, it will be around 2 to 3%. So please see and read carefully what has been asked. Okay. So if it is an early pregnancy unit, the incidence is around 2 to 3%. Now, what exactly the early pregnancy unit and what are the roles, and that we will see in the subsequent NICE guideline when we will discuss. Okay. So diagnosis of ectopic pregnancy is mainly by the ultrasound criteria. Transvaginal ultrasound TVS is the diagnostic tool of choice, and by visualizing an adnexal mass that moves separate to the ovary. Okay. So this is one of the important feature which you see on TVS. Other biochemical investigations in which is not useful is a progesterone, serum progesterone level. So never mark this particular as an option in your examination. Then serum beta HCG level is useful for planning the management of an ectopic which is seen on ultrasound. Now, what exactly the TVS features are? Again, here there are 2 or 3 SBAs. So please, you may take the photograph of this slide, or please remember there will be 2 to 3 SBAs on this particular slide. So diagnostic tool of choice is tubal ectopic pregnancy. Tubal ectopic pregnancy should be positively identified, if possible, by visualizing an adnexal mass which moves separate to the ovary. Now, what is the sensitivity and specificity of ultrasound in diagnosing ectopic pregnancy? It is around 87 to 99% sensitive, and specificity is around 94 to 99%. So it is in the range of 90 to 99%, both sensitivity and specificity. So this value is not going to be very, very important. So no need of worrying about this particular figure. But what is most important, the next is an ultrasound feature of ectopic pregnancy. An inhomogeneous or non-cystic adnexal mass is the most common finding in around 50 to 60% of cases. This is one of the frequently asked SBA. How does this ectopic look like on TVS? So it is the homogeneous or non-cystic, inhomogeneous or non-cystic adnexal mass seen in 50 to 60% of cases, while other features are empty extrauterine G-sac will be present in around 20 to 40% of cases, while extrauterine G-sac containing the yolk sac and or embryonic pole, which may or may not have cardiac activity. That means either live ectopic, or it may not be, cardiac activity may not be there, but you have a G-sac, you have a yolk sac, and the cardiac activity may not be there. So this live ectopic type of picture or without cardiac ectopic type is seen only in 15 to 20% of cases. So most common presentation is inhomogeneous or non-cystic adnexal mass. That is, so they will give you all these particular thing in option. Okay, inhomogeneous or non-cystic adnexal mass, extrauterine G-sac containing yolk sac, with cardiac activity, without cardiac activity, and what is the commonest TVS feature? So inhomogeneous non-cystic adnexal. Okay. In up to 20% of cases, the collection of the fluid may be seen in the uterine cavity, which is called as pseudosac. This is also one of the features which is seen in ectopic pregnancy. The key is to distinguish this from early intrauterine gestational sac. Now, there are two signs. One is a DDS, that is double decidual sign, and second is an intradecidual sign. These two features will differentiate this from ectopic. Okay, so in early intrauterine, you get an intradecidual and double decidual sign. Okay. Now, what this intradecidual sign is, it is described as a fluid collection with an echogenic ring located within the markedly thickened decidua on one side of the uterine cavity. And the double decidual sign is described as an intrauterine fluid collection which is surrounded by two concentric echogenic rings. So just remember intradecidual sign, double decidual sign, intrauterine gestation. Okay. So there may be anechoic fluid in the pouch of Douglas, which may be found both in intrauterine and ectopic pregnancies. So remember, anechoic fluid in the pouch of Douglas need not be an ectopic always. Okay, it can be seen in even intrauterine pregnancy. Second, echogenic fluid has been reported in 28 to 56% of ectopic pregnancy. It may suggest tubal rupture. Most commonly is due to the blood leaking from the fimbrial end of the fallopian tube. So whatever the echogenic fluid collection which is reported in 28 to 56% of cases, it may suggest tubal rupture. But most of the time it is due to the leakage of the blood from the fimbrial end of the fallopian tube. So it may be a tubal abortion also. Okay, so the cause of this fluid, echogenic fluid, is most commonly is the leakage from the fimbrial end of the fallopian tube. Okay. Now let's go to the various type of ectopics. So cervical ectopic. So from here onwards, we'll see the different types of ectopic and their features. So you may be given some ultrasound feature and you will be asked about the diagnosis. So we should know what are the typical features of particular ectopic pregnancy. So cervical pregnancy, ultrasound features will be empty uterus, there will be barrel-shaped cervix, and gestational sac lies below the level of the internal os, and absence of sliding sign and blood flow around the G-sac using color Doppler. So very simple. We are thinking about cervical ectopic. Cervical ectopic means gestational sac has to be below the level of the internal os, and uterine cavity will be empty. There will be blood flow on the Doppler. Okay. And there will be absence of sliding sign. This sliding sign will be positive in which cases sliding sign will be positive when there will be RPOCs. Okay. If you have written products of conception, they are not attached. They are lying in the cervical canal. So sliding sign will be positive. Okay. So this sliding sign is absent. Okay. In cervical pregnancy. Now biochemical investigation, serum beta HCG needs to be, we need to carry out. Okay. Then next is a cesarean scar pregnancy. The modality of choice is a TS as well as TVS. Other is MRI. Okay, so for cesarean you can do TVS. Additional TS can be performed, and further is second line investigation is MRI. If the diagnosis is unequivocal, diagnosis is equivocal, or there is a local expertise in the MRI diagnosis of cesarean scar, then you definitely go for MRI. No biochemical investigation is required. The next type is an interstitial pregnancy. Now, what is the ultrasonography criteria for interstitial pregnancy? We know in interstitial pregnancy where the pregnancy is lying. Pregnancy is lying in the interstitial part of the fallopian tube. That is the intramural portion. Okay, so there is an empty uterine cavity. Products of conception of the G-sac is located laterally in the interstitial part of the tube, and it is surrounded by less than 5 mm of myometrium in all imaging planes. Presence of interstitial line sign. So these are the features of interstitial pregnancy. So what we will think when we talk about the interstitial pregnancy, the gestational sac will be, where it will be located? It will be located laterally, located in the intramural portion. It will be surrounded by myometrium which is very thin, less than 5 mm. Okay, in all imaging planes. And the most important, interstitial will go with interstitial line sign. Okay, so these are the features for interstitial pregnancy. Ultrasound findings of 2D can be confirmed by 3D also. 3D USG can carry out, and differential diagnosis you have to think about the angular implantation in the lateral angles of the uterine cavity. That can be one of the differential diagnosis. Okay, so and MRI is going to be the helpful in considering the differential diagnosis of this. Now, what is the biochemical investigation? As usual, single serum beta hCG should be carried out at the diagnosis for and to help the management. In some cases, you may have to repeat it after 48 hours. Second is a cornual pregnancy. Now, see this interstitial we have just seen. Now, when we talk about cornual pregnancy, it means the pregnancy is located in one of the cornua. Okay, so visualization of the now here the cornua means it will be something like a corner of the uterus which is surrounded by the good size of the myometrium. So in interstitial you have a very thin myometrium, while here you will have a good size of the myometrium. Okay, so visualization of the single interstitial portion of the fallopian tube in the main uterine body. The gestational sac and products of conception are seen in the mobile, and they are separate from the uterus and completely surrounded by the myometrium, and vascular pedicle is adjoining this gestational sac to the unicornuate uterus. Okay, so these are the features in the cornual pregnancy. Now, what we are discussing is a different types of ectopic pregnancies and their ultrasonographic features. But at the same time, we should know about their management also, because the EMQs are asked on this. Okay, because the management, there are basically three options. One is a conservative or expectant management, second is a medical management, and third is a surgical management. And different types of ectopic will have a different type of management. Okay, so which management is suitable for which? So that is what is the learning point in our today's session. So in cornual pregnancy, I hope you have understood. We'll go ahead with the biochemical test will be single beta hCG at the time of diagnosis. You may have to repeat after 48 hours. Okay, ovarian pregnancy, no specific ultrasonographic criteria. A single serum beta hCG at the diagnosis and repeat beta hCG after 48 hours. Okay. The next is an abdominal pregnancy. The question has been asked in the past about the abdominal pregnancy also. The ultrasound criteria, defined ultrasound criteria can be used to diagnose the abdominal pregnancy. Definitely the uterine cavity will be empty, but you will see MRI can be useful for the diagnostic adjunct in the advanced abdominal pregnancy and can help to plan the surgical management. Please do not navigate my slides. Do not. So ultrasound criteria. So coming to the biochemical investigations. Let me share the presentation once again. So please do not change the slides. Okay. Abdominal pregnancy, the question has been asked in the past about the abdominal pregnancy. So MRI is one of the useful diagnostic adjunct in the advanced abdominal pregnancy, and it can help to plan the surgical management. So there is an important role for the MRI also. Biochemical investigation, high index of suspicion is based upon an increased beta hCG level in combination with the USG finding. Now here, when you talk about the abdominal pregnancy, the beta hCG, will it be very helpful? It may not be that helpful like a tubal ectopic pregnancy, because here there may be doubling like a intrauterine pregnancy, because pregnancy can grow to a larger extent. Okay, so what is most important is a high index of suspicion. Okay, next is a heterotopic pregnancy. Ultrasound criteria of heterotopic pregnancy, it is ultrasound findings demonstrate intrauterine pregnancy and a coexisting ectopic pregnancy. Again, beta hCG, will it be helpful in heterotopic? No, it may not be that helpful. So there are like heterotopic pregnancy, abnormal pregnancy, beta hCG you may have to do, but it may not be that helpful as it is helpful in the other types of ectopic. Now coming to the management options. Basically, as I discussed, there are three types of management. One is a surgical, second is a pharmacological, and third is a conservative. Okay, now the surgical management, where the laparoscopic surgical approach is preferable to open approach. For ectopic, it is always a laparoscopic approach. Okay, unless the patient is hemodynamically unstable. Okay, then salpingectomy. There are two ways of management by laparoscopy. One is a salpingectomy and second is a salpingotomy. Now the questions are asked about this, and please listen this particular slide very carefully, because the management depends upon the associated subfertility factors in the patient. So salpingectomy in presence of healthy contralateral tube perform in preference to salpingostomy. So if you are given a scenario where there is a diagnosis of tubal ectopic pregnancy and it is mentioned that there is no associated high risk factor for the subfertility, then the treatment of choice will be laparoscopic salpingectomy. So you have to read the scenario carefully and understand what exactly the situation is. Second option, second way of management is a salpingotomy. Okay. So in salpingectomy, if there is a history of fertility reducing factors, like a previous ectopic pregnancy, contralateral tubal damage, or previous abdominal surgery, previous pelvic inflammatory disease, etc., in that particular case, we will go for salpingostomy. So in the scenario which is given to you, if there are certain factors like there is a history of previous PID, the patient is a known case of PID, etc., we are going to go for salpingotomy. And not only that, what will be the future outcome in each, with subfertility factor and without those are also SBAs. So please listen carefully. Okay, so if a salpingotomy is performed, women should be informed about the risk of persistent trophoblast. So when you do the salpingotomy, there is a risk of persistent trophoblast and you require serum beta HCG follow-up. Okay, they should also be counseled that there is a small risk that they may need further treatment, okay, in form of either methotrexate or salpingectomy. So when you do this particular laparoscopic salpingotomy, further salpingectomy may be required or maybe methotrexate, and there is a risk of persistent trophoblast. And in what percentages there is a risk, these are also SBs, we will see in the subsequent slide. So coming to the systemic methotrexate, that is the medical management. So it should never be given at the first visit. That is point number one, unless the diagnosis of ectopic pregnancy is absolutely clear and viable intrauterine pregnancy has been excluded. Now the dose of methotrexate, you know well, it is 50 milligram per meter square. Now what is the monitoring? Remember the monitoring in each different types. Okay, so serum beta HCG here, what we do it on day 4 and day 7 post methotrexate. If the serum beta HCG level decreases by more than 15% between days 4 and 7, okay, the beta HCG levels are then measured weekly until less than 15 international units per liter. Listen this carefully. Remember this carefully. Serum beta HCG level in methotrexate. How do you monitor? You repeat beta HCG on day 4 and day 7. Okay. Then how much should be the decrease? The decrease in the beta HCG between day 4 and day 7 should be more than 15%. If you find it is decreased more than 15%, after that you will carry out weekly. Okay, after that you will carry out weekly till what? Till it becomes less than 15 international units per liter. Now, here they confuse a lot. We'll repeat on day 2, day 4, day 7. We'll repeat on day 4, day 7. You will have at least 15 options. Okay, then they will give that it is decreased more than 15%, more than 20%. So they put the various figures here in EMQ and they will ask you what is the follow-up in this particular. So a scenario will be given, long scenario will be given, medical management is given, and you will be asked about the follow-up. Okay, so the follow-up is day 4 and day 7 methotrexate. The beta HCG level should be decreased by more than 15%, and after that you go for weekly follow-up. Okay, until it, and when you read the NICE guideline, here they have given less than 20 international units. So sometimes if they pick up the option from the NICE guideline, you will have the here 20, both are correct. 15 is also correct and 20 is also correct. When we will see the NICE guidelines subsequently after this, you will realize this particular difference. Okay, so both are correct, but only one option will be there in the final examination. So suppose if you remember this 15, you may have little confusion if they give 20. Okay, if the level does not decrease by 15%, so another thing is that sometimes they give you in the scenario that the level repeat beta HCG they will give day 4 level, day 7 level, but it is not decreased by 15%. What is the next step? So the next step here is most of the time candidate answer repeat the methotrexate. No, what you have to do, you have to repeat the transvaginal ultrasound and exclude the ectopic fetal cardiac activity and the presence of significant hemoperitoneum. So what is going to be the next step if your beta HCG is not decreased by more than 15%? So you have to repeat the TVS. So the next step here is a repeat TVS and not the repeat methotrexate. Okay, here is a commonest mistake which is done by the most of the candidates. So first you do the TVS, exclude the ectopic fetal cardiac activity and presence of significant hemoperitoneum, and then you go for administration of the second dose of methotrexate. Is it very clear to all of you? Okay, now they ask you about this particular figure. Success rate of single dose of methotrexate is 65 to 95%. And how many people require, how many ladies will require a second dose? Around 3 to 27% of women will require a second dose. So these are the numericals. You will make a separate page in your note on only numericals. Okay, so this figure you will remember: 65 to 95% success rate for methotrexate, and 3 to 27% will require a second dose. Now the next type of management is expectant management. It is an option for clinically stable women with UAG diagnosis of ectopic pregnancy and beta HCG level is decreasing, and initially it is less than 1,500. So if you have a beta HCG which is showing the decreasing trend and initial beta HCG is less than 1,500, she may be given expectant management. So they may give 2-3 scenarios on ectopic, and they will ask you about the choice of treatment. Okay. Now coming to the next type of pregnancy, cervical pregnancy. So in cervical pregnancy, medical management with methotrexate can be considered for cervical pregnancy. Remember, cervical pregnancy, if you go for surgical management, you are going to have a severe bleeding. So try to remember type of ectopic and whether it is medical, surgical, what type of management it is. In cervical, it is a medical management is superior. Okay, surgical management has got a high risk of failure and reserved for those women suffering from life-threatening bleeding. Okay, so medical management in cervical with methotrexate can be considered. Then cesarean scar pregnancy. Cesarean scar pregnancy per se have both actually option, but associated with severe maternal morbidity and mortality. So medical and surgical interventions with or without additional hemostatic measures should be considered in women with first trimester cesarean scar pregnancy. There is insufficient evidence to recommend any one specific intervention over another for cesarean scar pregnancy, but the current literature supports a surgical rather than medical approach as the most effective. So when you have a cesarean scar pregnancy, what does the Green Top guideline says? Insufficient evidence to recommend any one specific intervention or the another for cesarean scar pregnancy, but the current literature supports a surgical rather than medical approach. Okay, so is it very clear? There is a separate talk on cesarean scar pregnancy. We will cover today. We are not going to cover, but subsequent sessions we will be covering that particular talk. Also, there are multiple types of management for cesarean scar pregnancy that we will be discussing. Now coming to the interstitial pregnancy. So non-surgical management. So interstitial also, what happens? It is located in the intramural portion. So if you operate there, again there is a high chance of bleeding. Okay, it's very difficult to operate. Difficult to means you are likely to have complications. So here also you will have a medical management. So non-surgical management is acceptable option for stable interstitial pregnancies. Expectant management is only suitable for women with low or significant falling beta HCG levels in whom addition of methotrexate may not improve the outcome. Okay, so pharmacological approach using methotrexate has been shown to be effective. So interstitial pregnancy, pharmacological methotrexate, although there is insufficient evidence to recommend local or systemic approach. Surgical management by laparoscopic corneal resection or salpingostomy is also an effective option. Okay, so but preferably stable for patient, go for methotrexate. Alternative surgical techniques could include hysteroscopic resection under laparoscopic or ultrasound guidance. There is insufficient evidence on safety and complications in future pregnancies to recommend other non-surgical method. Okay, so that is about the interstitial pregnancy. Coming to the coronal pregnancy, we know that the pregnancy is located in one of the corns, so surgical option is going to be the better here. So management is by excision of the rudimentary horn via laparoscopy or laparotomy. Next is ovarian pregnancy. For ovarian pregnancy, laparoscopic approach and surgery. Okay, so if definitive surgical treatment is performed, if the laparoscopy is required to make the diagnosis of ovarian pregnancy, ovarian ectopic pregnancy. Systemic methotrexate can be used to treat the ovarian ectopic pregnancy when the risk of surgery is high or post-operatively in presence of persistent residual trophoblast or persistently raised beta HCG. Okay, so here the definitive surgical treatment is preferred if the laparoscopy. So you are going to diagnose this ovarian pregnancy by doing laparoscopy. So try to treat at the same time. That is what the guideline says. Okay, but medical management also has got some role if the risk of the surgery is too high or post-operatively you have operated but there is a persistent trophoblast. In that particular case, post-operatively you will give methotrexate. Okay, so you need to look into the scenario what the information is given, and accordingly you have to select option. The next is abdominal pregnancy, early abdominal pregnancy, laparoscopic removal. Alternative method will be systemic methotrexate with ultrasound guided feticide. That can also be used. The second, for advanced abdominal pregnancy, it is laparotomy. Okay, so abdominal pregnancy always divided into two, early and late. Early, you can go for laparoscopic removal, while in late or in advanced, you have to go for laparotomy. Okay. Next is a heterotopic pregnancy. Remember, heterotopic, you will have intrauterine and extrauterine pregnancy or the ectopic pregnancy. Here, the patient should be interested, not interested in the intrauterine. Then only you will go for medical management with methotrexate. But generally, these patients will be IVF patients. So, what exactly the guideline says? Listen carefully. The intrauterine pregnancy must be considered in the management plan. Methotrexate should only be considered if the intrauterine pregnancy is non-viable or the woman does not wish to continue the pregnancy. So heterotopic pregnancy generally is surgical management. Okay, because if the patient is interested in continuation of the intrauterine pregnancy, you cannot go for medical management. What you can give is a local injection of KCl or hyperosmolar glucose with aspiration of the sac contents is an option for clinically stable women. Okay, but methotrexate is not a good option for the patients who wants to continue the pregnancy. Surgical removal of an ectopic pregnancy is the method of choice for both hemodynamically unstable as well as hemodynamically stable women. So heterotopic pregnancy, surgical removal for stable patients as well as unstable patients. Okay. Expectant management is an option for heterotopic pregnancy where the ultrasound findings are of non-viable pregnancy. Okay. Next, you will go for offer anti-D prophylaxis as per the national protocol. All RHD women, RH negative women will be given who have surgical removal of ectopic pregnancy or where the bleeding is repeated or heavy or associated with abdominal pain. Then long-term fertility prospectus following ectopic pregnancy. What does the guideline say? In absence of history of subfertility or tubal pathology, women should be advised that there is no difference in the rate of fertility irrespective of the management. So if the patient does not have any other factor for subfertility, then the tubal patency rate and future tubal ectopic pregnancy rates and the fertility potentials are same. Okay, so women with a previous history of subfertility should be advised that the treatment of their tubal ectopic pregnancy with expectant or medical management is associated with improved reproductive outcomes compared with the radical surgery. So here, if you see the further outcome in the subsequent pregnancies or repeat ectopics, it depends on the associated subfertility factors. If there are no subfertility factors, then there is no difference. But if there is a associated subfertility factors, then the expectant or the medical management is associated with improved reproductive outcome. Okay, so women receiving methotrexate for the management of tubal ectopic pregnancy can be advised that there is no effect on ovarian reserve, and if she, by any chance, if she undergoes uterine artery embolization and systemic methotrexate for non-tubal ectopic pregnancy, they can be advised that live births are known to happen. Okay, so women undergoing laparoscopic management of ovarian pregnancy can be advised that their future fertility prospectus is good. Then coming to the surgical management. Okay, now there are certain figures which are very, very important from SBA point of view. So please listen to this particular slide carefully. Okay, there is a multicentric RCT on laparoscopically confirmed tubal ectopic pregnancy and healthy contralaterality. So now we are talking about surgical management. We are talking about there are no associated subfertility factors, and the opposite tube is healthy. In that particular case, the cumulative ongoing pregnancy rate is 60% after salpingostomy and 56% after salpingostomy. Laparoscopy, we have two approaches. One is a salpingostomy you can do, or salpingostomy. And on which factor, associated subfertility factor, we are going to decide which we are going to do. But if you have a healthy contralateral tube, both will have a same rate, 56% and 60%. That means there is no much statistically difference. But the persistent trophoblast occurred more frequently in the salpingostomy group, that is 7% versus less than 1%. Okay, so if you have a healthy contralateral tube, the outcome is going to be same. Cumulative ongoing pregnancy rate will be same in the range of 60%, but salpingostomy group will have a 7% chance of persistent trophoblast as compared to the salpingectomy. Only less than 1% there will be chance. And remember, the option will be less than 1%. They will give you 1% also and less than 1% also. So you have to select less than 1%. Okay. So repeat ectopic pregnancies occurred in 8% in salpingostomy group and 5% in the salpingectomy group. So if you go for salpingectomy, persistent trophoblast rate is also less. Repeat ectopic chance is also less. It is less than 5%. It is less than 1%. Okay, if it is a salpingectomy. If it is a salpingostomy, then repeat ectopic around 8% and persistent trophoblast around 7%. Okay, so now let's see about the subsequent pregnancy outcome. Ectopic pregnancy with subfertility factor. Now we are dealing with ectopic which has got associated subfertility factor. Then what does the guideline say? If you go for salpingostomy, that is a conservative surgery, the 75% intrauterine pregnancy rate. So better outcome if you go for salpingostomy. While if you do salpingectomy in presence of fertility associated factors, then it is just 40%. Okay, so here you find a difference in the pregnancy outcome. Okay, so subfertility factors, it is better salpingostomy. 3 out of 4 will have good outcome. Okay, ectopic without subfertility factors greater than 90% in both groups. Okay, so without subfertility factors, there is not much difference. So NICE recommends that women undergoing salpingostomy have a serum beta hCG level taken 7 days after surgery and then weekly until a negative result is obtained. So if, because we know that how much is the persistent trophoblast rate, salpingostomy, it is in the range of 7%. So we have to do beta hCG after 1 week and after 7 days and repeat weekly till it becomes negative. Okay. And this persistent trophoblast rate is 3.9 to 11% after salpingostomy. Here they have mentioned 7%. Here they have given 3.9 to 11%. That is, average is around 7%. But option maybe 3.9 to 11% also. There may be answer as a 7%. So both figures are correct because here the average is also 7%. Okay. Now this is the slide. Okay, the same what we have discussed. Now here, this case, just a moment, I'll just salpingostomy, you have two groups, salpingostomy group and salpingectomy group. So if intrauterine pregnancy rate, ectopic with subfertility factors, the salpingostomy group has got a 75% intrauterine pregnancy rate, while 40% in salpingectomy group. And intrauterine pregnancy rate is 90% in both cases if the ectopic without subfertility. If there are no subfertility factors, then the intrauterine pregnancy rate is very, very good. Okay. And persistent trophoblast is 3.9 to 11%. We have seen this is a SBA. It can be 7% as an answer also. Okay. And for a persistent trophoblast, what we have to do? We have to do the hCG level and repeat weekly. Okay. So these are the things what we need to do. Okay. So predictors of success. Now, when you give medical management, that is the methotrexate, what are the predictors of success? There are 4 different predictors of success, in which one is a initial serum beta hCG level. So if you have a serum beta hCG level less than 1000, the success rate is 81 to 98%. If the beta hCG levels is greater than 5000, then success rate is around in the range of 38%. Okay, so up till now they have not asked any question on this, but by any chance they may ask you that she wants to know about the success rate, and this is what is the beta ICG value. Okay, the patient wants to know. So if the beta ICG is less than 1000, the success rate is 81 to 98%, and beta ICG levels are greater than 5000, it drops down to 30%. Now, ultrasound appearance of the ectopic. So if you have a live ectopic pregnancy, obviously methotrexate will not work, so the predictors will be high chance of failure. The presence of yolk sac, fetal pole, and fetal cardiac activity are significant predictors of failure. Success rates are higher when there is no GSAC visualized. Okay. Now, what are the other predictors of success? One is a pre-treatment changes in the serum beta ICG. So we are repeating the beta ICG 2 times. After 48 hours, we are repeating beta ICG. Now, if the in between the two beta ICGs, there is an increase in the beta ICG up to 11 to 20% over 48 hours prior to the methotrexate, then it has got a higher success rate. So if up to 20% there is an increase, it is okay. But if the beta ICG increases more than 20%, then the success chance will be less. Okay. Then decrease in beta ICG from day 1 and day 4. Now, actually, what we have seen day 4 and day 7 is the management protocol. Okay, monitoring. But between day 1 and day 4, if you measure the level and if you see that the beta ICG is decreased from day 1 to day 4 post administration methotrexate, so the chance is 88 to 100% if the serum beta ICG is decreased in these particular things. However, if it is between day 1 and day 4, if the beta ICG is increased, the chance of success is 42 to 62%. These predictors of success have not been asked, but I just wanted to cover by any chance they may ask about this. Now, the same thing what we have discussed here, I have tabulated here. So initial beta ICG, if it is less than 1000, then chance is 81 to 90% for that is a higher chance of success. If it is more than 5000, there is around 38% chance of the lower success rate. Then ultrasound appearance, if there is no gestational sac, high success rate. If there is a yolk sac, fetal pole, fetal cardiac activity, then these are the predictors of failure or the lower success. This is what we have discussed up till now. And there are another two predictors, that is pre-treatment change in the serum beta ICG. Okay, so over 48 hours we are monitoring. So if it is up to 11 to 20% increase, in that particular case, the chance of success with methotrexate is high. And post-treatment between the day 1 and day 4. Okay, if there is a decrease in the beta ICG between day 1 and day 4, there is a high chance, around 88 to 100% success, and increase in the beta ICG will have less, that is 42 to 62% chance of success. I hope you are getting this. Okay, now coming to the methotrexate, you have to avoid alcohol, folate containing vitamins during the treatment with methotrexate. There are adverse effects. Sometimes they can ask you about the adverse effects. Bone marrow suppression, pulmonary fibrosis, non-specific pneumonitis, liver cirrhosis, renal failure, gastric ulceration. So these are the side effects. But the most common, if they ask you, excessive flatulence and bloating due to intestinal gas formation, a transient mild elevation in the liver enzymes, and stomatitis. So if they ask you about the most common, then it will be excessive flatulence and the bloating. Okay. So this is about the methotrexate. Now, who is the good candidate for methotrexate? The patient who is hemodynamically stable. The beta ICG, ideally it should be less than 1500, but it can be up to 5000. No, there is no fetal cardiac activity on ultrasound. Certainty that there is no intrauterine pregnancy, and the most important thing, but the most forgotten, is a willingness to attend the follow-up. Okay, and no sensitivity to methotrexate. So patient should be willing to, because it is a follow-up, you are giving medical management, so patient has to be under supervision. Okay, so these particular things you should remember. The patient should be hemodynamically stable, beta ICG should be less than 1500, but you may consider it up to 5000. There should be no fetal cardiac activity, and there should be no intrauterine pregnancy, and the patient should be willing for follow-up. Okay, but now let's see about the what does the NICE say. NICE recommends that methotrexate should be the first line management for women who are able to return for follow-up. So the follow-up is the most important thing if you think about the medical management. And there is no significant pain, unruptured ectopic with mass smaller than 35 millimeter, with no visible heartbeat, beta HCG between 1,500 to 5,000, no intrauterine pregnancy as confirmed on the ultrasound scan. No statistical differences in the rate of recurrent ectopic pregnancy, with most long-term follow-up studies quoting in the range of 18.5% irrespective of the mode of management. So whatever is the mode of management, the recurrence of the ectopic pregnancy which has been reported is 18.5%. Okay. So that finishes our GTG of ectopic pregnancy. Is it very clear? There are many numericals. There are various concepts here. I hope you have cleared. Any doubt you want to ask now? Dr. Sinchana?
No, sir. No, sir.
No. Everything is clear?
Yes, sir.
Yeah. So today's session is going to be a little longer session because I have got many things to cover. Okay. So now let's see, we continue with the ectopic pregnancy again and miscarriage from the NICE guideline. Okay. So now here there will be repetition. So we will skip certain things which we have already discussed. Okay. Now here there is a concept of early pregnancy unit. Okay. So early pregnancy assessment services. So regional services should be organized. What does the NICE guideline says? How the services should be organized? So that an early pregnancy assessment service is available 7 days a week for women with early pregnancy complications, where scanning can be carried out and decisions about management is made. So there is a concept of early pregnancy assessment unit. Now these locations you should remember, because what happens here in our setup, you have just an antenatal opening. They have got a different early pregnancy unit. Now what is the location of early pregnancy unit, that you should know. We should know when the patient will go for A&E, that is accident and emergency, when the patient will go for gynecological service, when the patient will go early pregnancy unit, because sometimes they ask these questions. Okay, so an early pregnancy assessment service should be dedicated. So what are the services which are available? A healthcare professional who is trained and competent to diagnose and care for women with pain and bleeding in early pregnancy, and there should be facility for ultrasound also and assessment of beta HCG. So these are a couple of things which are done in early pregnancy unit. You have a trained ultrasound consultant, ultrasound facilities available, beta HCG facilities are available, and you are dealing with the early pregnancy with pain and bleeding. Okay, so staffed by the healthcare professional with training in sensitive communication and breaking barriers. Okay. Now, symptoms and signs of ectopic pregnancy in initial assessment. So, refer women with significant pain, bleeding, or hemodynamic instability to A&E. So, when there is a scenario where there is a significant pain, bleeding, and especially the hemodynamic instability, these patients will not go to early pregnancy unit. These patients will go to A&E. Okay. Then ectopic pregnancy can present atypically with varied symptoms, even with uncommon ones. Most important symptoms of ectopic pregnancy include, so common symptoms are pelvic pain, then there is amenorrhea, vaginal bleeding, etc. There are other reported symptoms like breast tenderness, GI symptoms, dizziness, fainting, syncope, shoulder tip pain, urinary symptoms, passage of tissue, rectal pressure. These particular questions you just have to remember because they will be part of your scenario. Okay, so these symptoms, if they are present, you think about whether you are dealing with ectopic or not. Okay, not only that, especially in part 3, when you take you have the information gathering, these particular things you have to ask, especially the other reported symptoms also. Okay. Next is what are the signs? You will have common signs such as pelvic tenderness, abdominal adnexal tenderness, and abdominal tenderness. And other reported signs are cervical motion tenderness, rebound tenderness, or the peritoneal signs. There will be pallor, abdominal distension, enlarged uterus, tachycardia, hypotension, shock, etc., etc. So in women of reproductive age, consider pregnancy even with non-specific symptoms, and ectopic pregnancy can mimic GI or urinary symptoms also. Okay. A healthcare professional should have access to the pregnancy test, immediately refer women with positive test and abdominal and pelvic or cervical motion tenderness to early pregnancy unit, or out of hours the patient will go to gynecological services. So if the scenario mentions that the lady has come at 8 o'clock in the evening, there is a positive pregnancy test, early pregnancy, and she will go for out of office hours, she will be referred to the gynecology services. Okay. If the patient is hemodynamically unstable, the patient goes to A&E. And if there is a early pregnancy unit in office hours, she will go to early pregnancy unit. Okay. Always consider ectopic pregnancy even without risk factors, as 1/3 may have none. So when you are thinking about ectopic pregnancy or talking about the high risk factors, 1/3 patients with ectopic pregnancy will not have any risk factor. Okay. So refer women with early pregnancy symptoms, pain more than 6 weeks of gestation or uncertain gestation to early pregnancy unit or out of our office hours. She will go to gynecologic services based on clinical urgency. Okay. So expected management for women less than 6 weeks of gestation, there is a bleeding but no pain and no risk factors. Okay. Now this particular question is always asked, especially in first 15 SBAs in paper 1. You will have such kind of scenario where you will be given, it is an early pregnancy and there is a bleeding but there is no pain. Okay. And there are no other high risk factors for ectopic. Okay. So in that particular case, what is the management? Advice written: if the bleeding continues or pain develops, you have to repeat the pregnancy test after 7 to 10 days. And if the test is negative, that means there is a miscarriage. If the test is positive, return for assessment. Here they have not mentioned about the TVS, or if they have not mentioned about the ultrasound. Basically, they want you to know that here we are not suspecting ectopic. There are no risk factors. Okay. So in that particular case, the expectant management is indicated. So you have a scenario where there are no risk factors for, in that particular case, you go for expectant management. You ask her to follow up after 7 to 10 days and repeat pregnancy test. If the pregnancy test is positive, then you will further reassess. Okay. If the test is negative, in that particular case, the pregnancy has completely miscarried. But if the patient has got worsening symptoms suggestive of ectopic pregnancy, then she will go to early pregnancy unit or out of office hours to gynecological service. Okay. Then urgency, immediate or within 24 hours, depending upon the clinical condition. So this is just, you should know what exactly the management, conservative management in early pregnancy bleeding. So that is just an early pregnancy. We are not suspecting ectopic pregnancy. Please remember. Okay. Now, what is the diagnosis of viable intrauterine or ectopic pregnancy? The modality of choice is an ultrasound. It is always a TVS. Okay. So you have to decide the location of the pregnancy, fetal pole, heartbeat, that exactly you are going to see on ultrasound. You will consider transabdominal when the uterus is enlarged, or if there is associated pathology like fibroid or ovarian cyst, then you will give transabdominal. Otherwise, it is always a TVS. Okay. If TVS is denied in that particular case, go for transabdominal scan or explain its limitation. Now, ultrasound scan findings and follow-up. General principle is that diagnosis of miscarriage via single scan is not 100% reliable, especially in very early gestation. If fetal pole is visible but no fetal heart rate on transvaginal scan, measure the CRA. So when there is a early pregnancy and when there is a bleeding, in that particular case, the ultrasound may not always be 100%. Our modality of choice is a transvaginal ultrasound. Then here there will be question always. Okay, so what you have to do when you do the TVS, here the table has not come properly. When I'll upload the PPT, I will upload the corrected PPT. What you have to do when you are doing a TVS, you have to measure the either CRL or mean gestational sac. If the CRL is less than 7 millimeter, in that particular case, you will advise to follow up TVS after 1 week. Okay, so you measure the CRL. Okay, if the fetal pole is visible but there is no heartbeat, you have done the TVS and there is no there is a fetal pole but there is no heartbeat. In that case, you will measure the CRL. If the CRL is less than 7 millimeter, you will advise the patient to repeat TVS after 1 week. That is, repeat after 7 days. Okay. Now, if the CRL is 7 millimeter or more, remember they'll give you option as exactly 7 millimeter in the scenario. Then you get confused where to, whether she, in which, whether to treat this as a less than or more than. Okay. So if it is a 7 or more, in that particular case, you have to seek the second opinion and also you have to advise the repeat TVS after 1. Okay, so if it is a CRL less than 7 millimeter, you will advise TVS after 1 week. If it is 7 millimeter or more, in that particular case, take the second opinion, and or the patient will come for follow-up after 1 week for TVS again. Okay, now if the fetal pole is not visible in that particular case, what you do, you can also measure the mean sac diameter. Okay, so in the scenario, see what they have given, whether they have given CRL measurement or mean gestational sac measurement. So mean, if they have given MSD, that is the mean gestational sac diameter, in that particular, the cutoff point is 25 millimeter or more. If it is less than 25 millimeter, in that particular case, again you will call her for after 7 days. Okay, so 7 days is the cutoff, because you don't see the fetal heart rate or the fetal heartbeat if the CRL is less than 7 or mean gestational sac is less than 25 millimeter. You don't see the heartbeat, so you have to wait till that time. So you ask for follow-up after 7 days, provided it is a TVS. TAS criteria are different, TVS criteria are different. Okay, and this is a typical SBA which is always asked. Every examination this is asked. Okay, if the gestational mean sac diameter is more than 25 millimeter, in that particular case, what you will do, you will take the second opinion, and also you will advise to repeat the TVS after 7 days. Okay, now if you are doing the transabdominal ultrasound, in that particular case, whether it is a CRL which is less than 7 millimeter or mean gestational sac which is less than 25 millimeter, what you will do, you will advise follow-up after 14 days. Okay, so transabdominal follow-up is after 14 days, while TVS follow-up is after 7 days. Okay, but less than 7 millimeter, more than 7 millimeter, there is a difference in the management. And mean gestational sac diameter less than 15 millimeter, less than 25 and more than 25, there is a difference. Okay, now, what are the important notes? Do not rely on the LMP alone to assess the gestational sac or determine if the fetal heartbeat should be seen in women. LMP may not always be accurate. Okay, and waiting for repeat scan does not harm the pregnancy. You will always give 24/7 contact number. Okay. Now, diagnosing the complete miscarriage. If no prior scan is confirmed intrauterine pregnancy and complete miscarriage is suspected, consider pregnancy of unknown location and arrange follow-up SCG repeat scan until the diagnosis is confirmed. Now, when you are, if there is no previous scan, there is a bleeding and you don't see anything intrauterine pregnancy, there is a possibility that there can be complete miscarriage. Okay, or other possibilities, it can be a pregnancy of unknown location. Now, what is the condition of pregnancy of unknown location? Where there is a beta HCG positive, but intrauterine you do not see pregnancy. That is called as pregnancy of unknown location. So this question is also asked about the management of pregnancy of unknown location. Now here there are 2 or 3 things about the ectopic. What are the signs which indicate the tubal ectopic? When you see a gestational sac and a yolk sac, that is a high diagnostic certainty, and gestational sac with fetal pole, which may or may not have a heartbeat, that indicates high possibility of tubal ectopic. Then you have a high probability of tubal ectopic if that means it supports the diagnosis but requires correlation. There is an adnexal mass which moves separately from the ovary. There is an empty G-sac, that is a tubal ring or bagel sign, a complex inhomogeneous adnexal mass. So these are the typical findings. They suggest the high probability of tubal ectopic. Okay, so high diagnostic criteria, proper G-sac is there, yolk sac is there, G-sac with fetal pole is there. So there is a high diagnostic certainty. There is a high probability of tubal ectopic when you see empty G-sac. Okay, that is a tubal ring, bagel ring, etc., etc. What you have to do? You have to consider the clinical presentation also. You have to see the other scan features also and take into account the serum beta HCG also. Okay, and signs suggest possible ectopic pregnancy. It requires further evaluation, like a uterus is empty, intrauterine fluid collection, you see pseudosac. So these are little features where there is a little confusion. Empty uterus is there, there is a pseudosac, and then in that particular case you have to differentiate intrauterine from extrauterine by DDS, that is a double decidual sign and intradecidual sign. Okay, so this is the thing. Now, key ultrasound consideration in early pregnancy. Check for the free fluid in the parental cavity or the pouch of Douglas. Now, we have seen that this can be present in extrauterine as well as intrauterine pregnancy also. But if it is a moderate to large amounts, it may indicate the hemoperitoneum. Okay, correlate with the scan findings, clinical presentation, and serum beta ECG before the diagnosis. Assess for heterotopic pregnancy. Always scan both uterus and adnexa during early pregnancy. This is the most important. When you do the TBS, you have to scan both uterus and adnexa. Ultrasound must be performed or reviewed by qualified professionals trained in the diagnosing ectopic pregnancy. Okay. Now, general principles in pregnancy of unknown location. This is also a pregnancy of unknown location. This is a question which is frequently asked. Assume ectopic pregnancy until confirmed otherwise. Do not use serum beta ECG alone to determine the pregnancy location. Clinical symptoms are more important than ECG levels. Okay, reassess if symptoms change and use serum beta ECG to assess tropoblastic activity and guide further management. Okay, because in here beta ECG will just tell you about the tropoblastic activity. Okay, so what is the monitoring protocol? Take 2 ECG measurements 48 hours apart. Okay, that will help in management, and further ECG test only after senior clinician review. Now, if you have a threatened miscarriage, how the threatened miscarriage is to be managed? If the fetal heartbeat is confirmed. Now, in threatened miscarriage, in a woman with vaginal, patient will have early pregnancy, vaginal bleeding, and there is no prior miscarriage. In that particular case, advise if the bleeding worsens or persists for more than 14 days. If the bleeding stops, she will continue for routine antenatal care. So this is also one of the frequently asked question, that you have a case, it is an early pregnancy, the diagnosis is a threatened miscarriage. Now, how will you manage? Now, here you have to think 2 things. One, whether she has got a previous miscarriage or not. If there is no, most of the time we immediately start with a progesterone. No, what does the NICE guidelines say? If she does not have a previous miscarriage, it is just a conservative or expectant management. She will come for follow-up after 14 days. Okay, if the bleeding start, then you continue her routine antenatal care. Okay, but if the patient has got a previous miscarriage and early pregnancy bleeding, then what you have to do, if the fetal heartbeat is confirmed and the woman has had a previous miscarriage, you will advise her micronized progesterone 400 milligram BD, okay, and continue until 16 weeks of pregnancy. Okay, so this is what is the management early pregnancy threatened miscarriage. I hope it is clear. Okay, most of the time you immediately start with progesterone. No, if there is a previous history of miscarriage, then you start with progesterone. You will continue till 16 weeks, and the dose is 400 milligram 2 times a day. Okay, now next, we have also seen the expectant management. So offer expectant management for 7 to 14 days if confirmed miscarriage. Consider alternative methods. So management of the miscarriage, there are basically, in miscarriage there are 3 ways of management. One is expectant management, second is a medical management, and third is a surgical management. Okay, now we have finished with the ectopic. Now we are into the miscarriage, NICE guideline. So here medical management means either mifepristone, misoprostol, etc., etc. Okay, surgical management will be MVA or dilatation, evacuation, etc., etc. Now, what exactly the guidelines is, says that, so they say that when you are thinking about the miscarriage, offer expectant management for 7 to 14 days if it is a confirmed miscarriage. Okay, alternative options like a medical or surgical if there is a risk of hemorrhage, that is late first trimester, or history of traumatic pregnancy. If she has got a previous pregnancy loss, then this expectant management is not suitable, because that will cause more trauma. She knows that there is no more pregnancy and she is continuing with it for another 1 to 2 weeks. So you don't have to select this expectant management there. You so read the question carefully. Risk for from the blood loss like bleeding disorders, refusal of transfusion, etc. Again, expectant management is not suitable. Or if there are signs of infection, again expectant management is not suitable. Okay, if expectant management is not acceptable, then go for medical management. Okay, counseling and follow. Explain expectant management clearly. including that most do not need further treatment, provide oral and written information on what to expect, pain relief options, etc., that you have to give. So what we have seen up till now, the conservative management or expectant management is one of the option which is given to the uh, uh, miscarriage patients. Okay. So if miscarriage completes within 7 to, now we are in expectant, what we are going to wait for 7 to 14 days. Now if the miscarriage completes within 7 to 14 days, what is the next step? UPT after 3 weeks. Okay. So urine pregnancy test is after 3 weeks. So this is also another question they will ask you about the next step. If you are dealing about the miscarriage and the miscarriage is complete, you have to advise the UPT after 3 weeks. That means the pregnancy event is over. Okay. So UPT after 3 weeks, this you please make a note when you are dealing with the miscarriage. Okay. If positive, she will return for individualized care. If the bleeding pain has not started or it is persisting or worsening, what will you do? You will repeat scan. Okay. Discuss all options, that is expectant, medical or surgical. So you have waited for 7 to 14 days, but there is no bleeding. Then in that particular case, what you have to do? You have to repeat the scan. Okay. And after that, you have to advise all three options. Okay. For those continuing expectant management, review condition at minimum 14 days after the initial follow-up. So after 2 weeks is the follow-up. Is it clear? Expectant management, miscarriage management. Is it clear, Dr. Sinchana, Dr. Sansi?
Yes, sir. Yes, sir.
Ah,
Yes,
yeah,
sir.
Yes,
yeah,
sir.
yeah. Okay. Now coming to the medical management of miscarriage. Now medical management is with the mifepristone 200 milligram orally. After 48 hours, you give misoprostol 800 micrograms. Okay, that is vaginal, oral, or sublingual route. So remember, mifepristone 200 followed after 48 hours, misoprostol 800 micrograms. Route is vaginal, oral, or sublingual. Do not give if gestation sac has already passed. So the medical management, we know this, we are doing it day to day. So medical management of incomplete abortion. Now, if it is an incomplete abortion, what is the difference? Here, only misoprostol 600 microgram is used. While when there is a only miscarriage, there is no incomplete, then you have to give mife plus miso. Okay, mife followed by miso 200 and 800. If it is an incomplete miscarriage, then misoprostol 600 microgram is given, or you can give 800 microgram, but there is no mifepristone they have mentioned. Do not use mifepristone for incomplete miscarriage. Okay. Then follow up after medical management. As you know that after miscarriage, what you have to do? You have to repeat the UPT after 3 weeks. If the test is positive, she will come for follow up to rule out return pregnancy, then molar pregnancy or ectopic pregnancy. If the test is negative, but there are ongoing symptoms, that is bleeding, pelvic pain, etc., in that particular case, we have to review further. Okay. So remember, you have to do the UPT after 3 weeks. Okay. So general information. Now expectant management we have seen. So we are going to wait for 7 to 14 days. So who are the eligible candidates? Okay. So woman who is clinically stable and pain free. Okay. Now this they are talking about the ectopic. So miscarriage is over now. This is the NICE guideline. They have in NICE guideline they have clubbed together. It is a miscarriage and ectopic pregnancy. So now they are talking about the ectopic pregnancy. This we have covered in the GTG. They are same. Okay. So we will skip this particular slide. Then monitoring protocol for expectant. Please remember here beta HCG is monitored on day 2, day 4, and day 7. What was the management for the medical management? That is methotrexate, Dr. Sinchana.
So
Medical management.
methotrexate dosage of 50 mg per meter square is
Ah,
given. Then a beta HCG is repeated on day 4 and day 7.
After that, what
After
you
that,
need?
if there is a increase of up to 15%, then it is repeated more than 15%. It is repeated weekly
Is it
till the
increase or
beta
decrease?
HCG is less than 15 international units per
Decrease.
liter.
Beta HCG should decrease. No, you are giving methotrexate, and the decrease should be
Yes,
more
sir.
than 15%. Okay.
Yes, sir.
But when you are giving a expectant management for ectopic pregnancy, what you have to do? You have to repeat the beta HCG on day 2, day 4, and day 7. Okay. Are you getting it? When you are giving expectant management for ectopic pregnancy, which are the cases which are suitable? That we have already seen in the GTG. For expectant management, the patient should be clinically stable, ectopic size should be less than 35, and serum beta acid, remember here it is 1000. Okay, for expectant it is less than 1000. Patient should be able to come for follow-up. Okay, so these are the features. And then follow-up is beta ICG on day 2, day 4, and day 7. If there is more than 15% decrease from the previous value, then we will continue to monitor beta ICG until less than 20 units per international units per liter. See here, they are talking about 20 international. There the limit was 15 international. So there is a little difference, but doesn't matter. Whichever option is there, just go for it. If no significant drop or rise or plateau, reassess and seek for seniors review. Okay. Then counseling points are there. Okay. Then medical management. This also we have seen no significant pain, unruptured ectopic less than 35 millimeter, no fetal heartbeat, beta ICG level less than 1500. Okay, expectant management it was 1000. Here methotrexate less than 1500. No intrauterine pregnancy on ultrasound. Women should be able to return follow-up. This all we have seen in the GTG. It is safe. So there is a choice between medical and surgical. If the beta ICG is between 1500 to 5000, if there is no significant pain, adnexal mass size is less than 35 millimeter, no fetal heartbeat, no intrauterine pregnancy, and the patient is able to follow up. So here there is a choice between medical and surgical. Okay. So if methotrexate is chosen, counsel on higher chance of needing further intervention or emergency admission in these particular cases. So you may go for medical management, but the higher chance of further intervention. Okay. So monitoring after methotrexate, that we have seen day 4, day 7. Okay. Then weekly. Okay. So this all we have seen. So we'll not go into detail. Then surgical management also offer surgery. Okay, who cannot return for follow-ups. There is significant pain, size more than or equal to 35 millimeter. Remember, it is more than equal to 35 millimeter. Okay, visible fetal heartbeat. Serum beta ICG more than 5000. Okay, laparoscopic, salpingostomy, salpingectomy, that everything we have seen. So this is just a repetition. Here again there is an SBA. Consider salpingostomy if there is a subfertility factors. Okay, up to 1 in 5 may need additional treatment like methotrexate or salpingectomy. So when you do salpingotomy, in that particular case, 1 in 5 will require additional treatment. So they may ask you this particular SBA, how many patients require a further treatment if you go for salpingostomy? 1 in 5 will require additional treatment. Okay, so this is once you do the salpingostomy, we have seen that beta ICG is to be monitored 7 days and then weekly. Okay, if you do salpingectomy, then UPT after 3 weeks. Okay, this after salpingectomy, it is something like a miscarriage. After miscarriage, we have seen that we are repeating the beta ICG after 3. Same, if you do the salpingectomy, you have to repeat the beta ICG or the pregnancy test after 3 weeks. Okay, so that finishes the NICE guideline about the miscarriage and ectopic also. Okay. So now we have got certain short topics, amniocentesis and CVS. Okay, this is green top guideline number 8. Okay, this is also frequently asked questions. Mainly they are asking about SBS from this particular topic. So they are asking about the risk of miscarriage. So additional risk of miscarriage after the amniocentesis or CVS by train operator is less than 0.5%. Amniocentesis timing not before 15 weeks, CVS not before 10 weeks, preferably from 11 weeks to reduce the technical challenges. So they are asking about the timing and they are asking about the risk of abortion. So a lot of numerical values are there. So here, please make the note of these numericals separately. So risk of abortion less than 0.5%. The timing of amniocentesis not before 15 weeks of gestation, CVS not before 10 weeks of gestation. Okay, preferably after 11 weeks only. Okay, in twins, additional risk of miscarriage after CVS amnio is 1%. So please read the question carefully. What you are asked, what you have been asked, whether the risk of miscarriage is asked in singleton pregnancy or whether the risk of miscarriage is asked in multifetal pregnancy. If the risk of miscarriage is in single pregnancy is less than 0.5%, not it is less than 0.5%. Okay, and here it is 1% if it is a multiple or the multifetal pregnancy. Okay, review bloodborne virus screening, viral load, antigen test, etc. before invasive test, and discuss individual transmission risk. Again, here there is a question which is asked. So investigations are given, but the HIV investigation is pending. So what you have to do the this particular investigation. Then only you will pose this case for the this test. Okay. Now CVS timing. The timing is between 11 and 13.6 weeks of gestation. So CVS timing is between 11 to 13.6 weeks of gestation. CVS can be performed between 14 and 40, up to 14.6 weeks of gestation in certain cases, but routine timing is 11 to 13.6 weeks. Amnio 15-week onwards. Okay, what are the additional risks? We have seen risk of miscarriage after CVS is 0.5% in singleton. After CVS and amnio, it is both 0.5%, and in multifetal gestation, it is 1%. Okay. Now, this particular thing you should remember. So they are asking about the second sampling, amniocentesis and CVS. This particular chart, sometimes it is asked. So second sampling or repeat procedure is required in around up to 6% of cases in amnio as well as CVS. Okay. Then they are asking about the blood stain sample. Blood stain sample is seen in around 0.8% of cases. That is seen in amnio only. CVS, it is not applicable only. Okay. Then you have confirmed placental mosaicism. Confirmed placental mosaicism is seen in less than 2%. Though these values you will find it difficult to remember, but sometimes they can ask these numericals also. Then how to remember? Okay, see, this is a MCC, that is the maternal cell contamination. Then you have a FCC or CCF, that is failed cell culture. Okay, so whatever you do, whether you do the amnio or CVS, we want to do the cell culture. The cell culture failure is the minimum, that is 0.5 to 1%. This MCC and FCC or CCF, they have a range. Okay, so these, if you see here, there is a range, here there is a range. So F comes before M or C comes before M. You remember CCF or you remember FCC, both these letters come before M. Okay, so 0.5 to 1% is the risk in cell culture failure in both cases. MCC again 1 to 2%. So remember 0.5 to 1%, 1 to 2%. Okay, then comes RTF, that is rapid test failure, is around 2%. Okay, so this is how you can remember this particular figure, because the option will be 1%, 0.5%, there will be 0.5 to 1%, etc., etc. So very confusing. So cell culture failure is the minimum, that is 0.5 to 1%. Then you remember maternal cell contamination 1 to 2%, and rapid test failure is seen in only 2% of cases. Okay. Then blood stain sample around 0.8% of cases, and confirmed placental mosaicism is applicable only in CVS, that is less than 2%. Here it is less than 2%. Rest of the things, infection, etc., etc., fetal injury, they are rare. Okay. The timing we have seen, so we will not go into the details of that. Again, here these figures are not very important, but only thing is just remember that Telepas equinovirus is common after early amniocentesis. Then early amniocentesis also resulted in requirement of multiple needle insertions, and early amniocentesis cytogenic implications with increased risk of failed culture. Okay, so risk of failed culture is also high with the early amniocentesis. Okay. I don't think here they are asking anything specific. Okay. The risk of associated third trimester diagnostic amniocentesis. Again, third trimester they have not asked up till now. Okay. The risk of preterm labor before 34 weeks of gestation is around 3 to 4% based on the limited trials. Okay. This they have not asked. So I'll skip this. Again, antiretroviral treatment should be optimized to aim for undetectable viral load prior to amniocentesis. So ART should be there, because the risk of transmission is very, very less. So this GTG is very small here. Only the timing and the transmission, these are the only things which they are asking. So remember those particular charts. Okay. So next is a small talk, that is cell-free fetal DNA. Okay. So here two things. One is a NIPT and second is a NIPD. There is non-invasive prenatal test and non-invasive prenatal diagnosis. Okay, so there is a question which is asked sometimes EMQ they are asking here. Okay, so what is the difference between NIPT and NIPD? Okay, this NIPT uses CFF, that is cell-free fetal DNA, to test for aneuploidy, as opposed to the non-invasive prenatal diagnosis, that is NIPD, which uses the cell-free fetal DNA to diagnose fetal sex, RH status, and monogenic disorder. So in diagnosis, it is a confirmatory, while here it is a screening test. NIPT is a screening test, while NIPD is you are directly diagnosing the fetal sex or RHD status or the monogenic disorders. So NIPT is a screening test and needs confirmatory invasive testing in cases of high risk of positive. Okay. NIPT demonstrates high sensitivity and specificity according to our recent meta-analysis, and it is less accurate, although it is less accurate for trisomy 18 and trisomy 13, monosomy X, and sex chromosomal aneuploidies than trisomy 20. So highest sensitivity and specificity is seen with trisomy 21. Okay. Now basis for NIPT technique. So cffDNA comprises what is the basis? This cell-free DNA comprises small fragments of fetal DNA thought to originate from the trophoblast. Okay, these fragments will circulate in the maternal plasma, and they will form around 10% of the DNA fragments in the maternal plasma. How much is the percentage in the maternal plasma for this CFF DNA? It's around 10%. Okay, it is present in reliably measurable levels for aneuploidy screening from 10 weeks of gestation. So from what is the weeks of gestation from where you can measure is around 10 weeks of gestation. Generally, the fraction is around 10%, but minimum fraction required is a 4%. Okay, so it is clear quickly from maternal circulation immediately after delivery. That is why it is very specific to that pregnancy. Now, what is the test accuracy? NIPT is very specific for trisomy 21 and trisomy 18, that has got a high sensitivity and specificity. Then results from trisomy 13 reveal a lower sensitivity. Exact reasons we do not know, but what has been proposed is a low GC content, low guanine and cytosine content known to exist in the chromosome 13, and monosomy X demonstrated reduced sensitivity compared to trisomy 21 and 18. So high sensitivity for these two, trisomy 21 and 18, while less for trisomy 13 and monosomy X. Okay, and what is the reason? The low GC content. Okay, just remember this couple of things. This I don't think it is very visible, but trisomy 21 and 18 has got high sensitivity, while trisomy 13 and monosomy X has got low. Okay, now what is the sensitivity? Sometimes they ask you about the multiple pregnancy. Okay, so trisomy 21 was detected at a rate of 93.7%. Okay, so if you see this chart now, the sensitivity is 99% for trisomy 21 in a singleton pregnancy. But if it is a multiple pregnancy, then trisomy 21 sensitivity is only 93.7%. Okay, so this is the only figure which you can remember here. Now, what happens in dizygotic twins? Okay, aneuploidy discordance is an issue, and nearly twofold intertwin difference in the CFF DNA. So what happens in dizygotic? The genetic content is different in dizygotic twins. Okay, so sometimes what happens? One of the twin is affected. Now the genetic content is different for the dizygotic twin, and the affected twin may have a fraction below the lower threshold, which is required 4%. Okay, so if the affected fetus is contributing less than 4%, then it will not be detected. Okay, so you have a dizygotic twin. One of the twin is affected. The affected twin is contributing less than 4% to the total fraction, then it will not be detected. I hope, and that will cause error in the interpretation. I hope it is clear to you. Okay. So while the unaffected twin may contribute a high cell-free fetal DNA fraction, therefore the total CFF DNA fraction may appear sufficient and produce a false negative or low risk result. Okay, so this is the challenge with the dizygotic twins. While monozygotic twins, it is very easy because they will have the same genetic content. Okay, so theoretically it should be easier as they produce identical DNA molecules, but chorionicity must be certain. So you have to be very, very sure about the chorionicity. So another problem is that of a single twin demise, as the effect of cffDNA from the demised twin has on the NIPT result is unknown. Because of this, professional bodies do not currently recommend NIPT for aneuploidy in the twin pregnancies. Okay, like RCOG, ACOG, they are not recommending it for the twin pregnancy. Now, NIPT in twins, the key points, whatever we have discussed, dizygotic twins, there is a discordant aneuploidy risk. Unequal cffDNA may cause false negatives. This we have seen. Okay, then in monozygotic twins, relatively it is easier as DNA is identical, but the most important, the chorionicity should be certain. Okay, the single twin demise, unknown impact on NIPT result. Current guidance, RCOG, ACOG do not recommend NIPT for aneuploidy in twins. Okay. Now, benefits of NIPT. It is non-invasive test, does not pose the risk of CVS or amnio, such as pain, small risk of infection, procedure-related miscarriage, etc. So that is what is the advantage. CFF-DNA is quickly cleared from maternal circulation. It is specific to that pregnancy. The test has a quick processing time. It is reported within 3 to 5 days, almost similar to Kiva PCR. Okay, so quantitative fluorescence PCR like this particular thing. Okay, so quick timing. Now, what are the disadvantages? Disadvantage also we have seen the accuracy is not 100%. Again, not only that it is a screening test. So sometimes you may get a false negative and false positive result. Occasionally, the test will produce inconclusive result. So what is the percentages of inconclusive result of NIPT? Around 1.9 to 6.4%. And whenever you get inconclusive result, you may have these patients have a high chance of chromosomal aberration. Okay, so common reasons for false negative and inconclusive result: a low fetal fraction in the fetal blood sample, okay, which is measured by specific markers of fetal DNA or algorithms applied to the sequential sequencing the data. So low fetal DNA fraction is one of the reasons, and vanishing twin that has disappeared prior to the woman's dating ultrasound, which if he has contributed can cause a false positive result. Okay, now what are the disadvantages? Confined placental mosaicism. The disadvantage, what happens in confined placental mosaicism, the fetal cell line is different, the placental cell line is different, so that can create a confusion. As the fetal DNA fragments originated from the placenta, NIPT is unable to distinguish between the two. Okay, so NIPT can detect maternal cancers and maternal copy number variants, which can cause false positive and have ethical implications. So these are the disadvantages with this. And NIPT has an effect on fetal medicine specialists. And because of the introduction of the NIPT, invasive tests are reduced by 53% in amniocentesis and 77% there is a reduction in the CVS. Okay, so that is one of the disadvantages. Okay, so that finishes these particular small topics. Okay, so we have not yet finished half the session also. We have just finished the ectopic and abortion. So we'll just take 1 minute break. I'll just drink a water and I'll be back. Okay. Even if you want to take 1 to 2 minute break, you can take. So welcome to the class again. So we will continue with abortion care NICE guideline. Okay. Now, what does the NICE guideline says about the abortion care? So it talks about the waiting times. What does it say? Ensure minimal delay in the abortion process. So once the patient comes to you with the intention of abortion, you have to assess that particular lady within 1 week of her request. Okay, so remember these timelines. You have to assess within 1 week of request, and you have to provide the abortion service within 1 week of assessment. Okay, so you have to assess within 1 week, and you will provide the service within 1 week of assessment. For abortions due to fetal anomaly, if the preferred method is not available in the maternity services, ensure clear referral and communication is given to the woman, and transfer smoothly to abortion services. Continue receiving support and access more information about the anomaly. Explain that the fetal anomalies may not have visible physical signs also. Sometimes, there are internal anomalies which may not, so that you have to do the counseling of the patient. Then what about the anti-D? Offer anti-D or to all Rh negative women who have abortion after 10 weeks of gestation, you will offer anti-D. Okay, not needed for medical abortion up to 10 weeks of gestation. This here is one of the question, that the patient undergoes medical abortion and she is Rh negative. What with the dose which is given? They'll give you different doses, but the most important thing is that the anti-D is not required up to 10 weeks of gestation in medical abortion. Okay, consider for surgical abortion up to 10 weeks of gestation. If it is a surgical abortion, you will consider. Okay, ensure Rh testing and anti-D supply do not delay care and are available at the time of abortion. Now, again, here the question are asked very frequently. Question is asked, especially maybe in first 20 SBAs you will get in paper 1. What is the antibiotic prophylaxis given in cases of abortion? Okay, so antibiotic prophylaxis not routinely needed for medical abortion. Again, they'll ask you the she has undergone medical abortion, what is the antibiotic? So no need of, they'll give you a list of options. It may be EMQ also, but for medical abortion not required. Okay, offer for surgical abortion, this antibiotic prophylaxis you will offer for surgical abortion. Now, what is the drug and dose? Please remember this. If using doxycycline, consider 100 milligram BD for 3 days. Most of us here, we use 5 days or 7 days, so we just select that particular option. Sometimes we select mixed antibiotic, like a combination of doxy plus metro. Though in practice sometimes we are using, please follow the guideline. Guideline says doxycycline 100 milligram BD for 3 days. That is the recommended. Okay, do not routinely combine metronidazole with another broad spectrum antibiotic like doxy for abortion prophylaxis. So doxy metro combination etc are not advised. Okay, then VTE prophylaxis, LMWH 7 days post abortion if pharmacological prophylaxis is needed. Start before and continue longer if VTE risk is there. We'll discuss about these VTE when we will cover the VTE. Okay, venous thromboembolism, separate guidelines are there that we will go into the details, because at least 5 to 6 SBAs and EMQs will be there on venous thromboembolism. Okay, like this, what we are going into detail, same we are going to go into details of that. Okay, now abortion method of choice. Offer medical or surgical abortion up to 23.6 weeks of gestation. Remember, what is the limit for which up to which you are going to offer? 23.6 weeks of gestation you will offer. So surgical after 23 weeks only if feticide is given by 23.6 weeks of gestation as per the Abortion Act clarification. So by any chance, if you need to do carry out after 24 weeks of gestation, then you have to give the feticide before 23.6 weeks of gestation. This is what the Abortion Act says, 2019. There is a clarification. Now, what is this clarification summary? The Department of Health and Social Care clarified that surgical abortion can be carried out shortly after 23.6 weeks if feticide was administered on or before 23.6 weeks of gestation. Sometimes, what happens on weekend, the patient gets admitted and there are some logistic reasons. Okay, so in that particular case, you consider feticide first. You give the feticide by 23.6 weeks of gestation, and then you carry out the surgical evacuation soon afterwards. After it's just after midnight or delayed because of logistics, then also you can perform even if this limit is crossed, provided the feticide is given before 23.6 weeks of gestation. It avoids legal risks to the providers and ensures compliance with the abortion. So this is what is the 2019 clarification summary. Okay. Now, abortion before confirmed intrauterine pregnancy. Is it mandatory that you need to have a confirmed intrauterine pregnancy? That means GSAC is seen, the fetal heart rate is not yet seen. Can you go ahead? Yes, you can go ahead. This is what the NICE guidelines says. Consider abortion before intrauterine pregnancy is confirmed. That is no yolk sac. If no signs of, provided there are no signs of ectopic pregnancy. Okay, in that particular case, also you can consider abortion. Okay, before proceeding, explain to the woman that there is a small risk of ectopic pregnancy. Follow-up may be needed to confirm abortion completion and rule out ectopic pregnancy. 24/7 emergency contact details will be provided. Okay, so these are the things which the NICE talks about the abortion. Then home expulsion. Okay, home expulsion is possible up to 10 weeks of gestation. Okay, so up to 9.6 weeks of gestation, offer home expulsion after the misoprostol. There is a little difference here at 10 weeks and up to 9.6 weeks. Okay, here offer home expulsion after misoprostol, but the misoprostol can be taken at home or clinic or hospital. So the misoprostol can be administered either at home, clinic, or hospital also. Okay, but if it is at 10 weeks, then home expulsion is possible after misoprostol, but misoprostol can be taken only in the clinic or hospital, not at home. This you have to remember, that if it is a home expulsion which is possible below 10 weeks of gestation, up to 9.6 weeks of gestation, she can take at home, but at 10 weeks of gestation, no, she has to take misoprostol at home. Okay, now this is also one of the frequently asked question about the doses. Okay, so up to 49 weeks of gestation, remember the dose of mifepristone is 600 milligram. When you terminate the pregnancy by medical methods using mifepristone and misoprostol, up to 49 days, it is 600 milligram orally, followed by 400 micrograms of misoprostol orally, or 1 milligrams of gemiprost vaginally. Okay, so up to 49 days, you have 600 mife and 400 miso. Okay, or 1 milligram of gemiprost. Then between 50 and 63, again you have two options. One is either you go ahead with a 600 milligram mife or 200 milligram of mife, either of these. Okay, followed by 1 milligram of gemiprostol, or followed by 800 micrograms of misoprostol vaginally. Okay, so if you give 600 milligrams mife, then you have to give 1 milligram of gemiprostol vaginally. Okay, between 50 to 63 days of gestation. Okay, so when you use gemiprost, the dose of mifepristone can be 600, can be 200 also, between 50 and 63 days of gestation. Here there is a lot of confusion, but you have to remember, as the gestation increases, the mife dose goes on decreasing. So up to 49 days, it is 600 milligrams of mife and 400 micrograms of miso, which is used. Okay, then when you use misoprostol, here this is 200 milligram, but it goes to 800 microgram. Okay, so this is what you need to remember. Same thing is given here, up to 49 days, 400 microgram we have seen. Okay, and it is 800 microgram vaginally up to 63 days. Okay, and mife dose is 600, and here the dose is mife 200. So these doses are also asked, so that is why I have written it. Okay, then medical abortion less than 10 weeks of gestation, the timing and options. Okay, standard option, that is interval treatment, mifepristone followed by misoprostol 24 to 48 hours. Please remember, when you are giving less than 10 weeks of gestation, the interval which is mentioned is 24 to 48 hours, not 36 to 48 hours. So you will see in the subsequent slide the difference here. Okay, so mifepristone followed by misoprostol after 24 to 46 hours. Okay, so another alternative is offer same days mifepristone plus vaginal misoprostol, but you need to explain high risk of ongoing pregnancy. So this is not generally, but what we follow is a mife followed by misoprostol. That is what is the routinely followed protocol. Okay, doses we have already seen. Now you have a medical abortion from 10.1 to 23.6. Okay, the dose obviously for MIFE will go on reducing. So here you remember 36 to 48 hours. There it was 24 to 48 hours. Here, as the 10 weeks you have crossed, your dose of MIFE has come to 200 milligram, and after 36 to 48 hours of interval, you will give 800 micrograms of misoprostol vaginally or 600 micrograms sublingually, and then you will repeat 400 micrograms either vaginal, buccal, or sublingual every 3 hours until expulsion. Okay, so MIFE plus meso dose after 10 weeks of gestation till 23.6 weeks of gestation, 200 MIFE, 36 to 48 hours. Remember, 36 to 48 hours here. Once you cross 10 weeks of gestation, then the start dose is 800 vaginally or 600 sublingually, followed by 400 every 3 hourly. Okay, so this protocol you have to remember. So look at the gestation age, what you are dealing, and accordingly select the dose of MIFE and meso. Very frequently asked question. Okay, the same thing I have mentioned here, what we have discussed. Okay, so this is just the repetition of the same table. Okay? Now remember this. Up till now we have seen 23 weeks of gestation, 23.6 weeks of gestation. Now we are going beyond 24 weeks of gestation. Now what is the dose? And again they are asking questions about these doses also. Okay. Now as the gestation increases, the meso dose will also come down. Okay. So up till now we have seen 800 followed by 400 3 hourly. Okay, between 10 weeks to 23.6 weeks of gestation. What was the dose of misoprostol? We are giving 36 200 MIFE, 36 to 48 hours. Then we will give 800 microgram miso, followed by 400 3 hours. Okay. Now see here. Now 24, your 24 weeks to 25 weeks. The dose of MIFE always remains same, while misoprostol dose, again it will come down to 400 microgram every 3 hourly. Okay, between 25 to 28 weeks of gestation, it is 200 microgram 4 hourly. Okay, 200 microgram 4 hourly. Okay, and here after 28 weeks of gestation, the dose of MIFE remains same, but the meso has come to 100 microgram 6 hourly. So the interval increases. Okay, so 24 to 25, meso you consider the dose has become 400. After 25, it is further, it has become 200. After 28, it has further reduced to half, that is 100 microgram. Now the interval between the doses is 3 hours after 25 weeks of gestation. Between 25 to 28 weeks of gestation, it is 4 hours, and then it goes to 6 hours after 28 weeks of gestation. Is it clear? Yes, Dr. Sansi,
Yes,
Dr. Sinchana, is it clear?
yes, sir.
Yes, sir.
Yes,
Yes,
sir.
sir.
Okay. Dr. Tony, Anthony, is it clear?
Yes, sir. Good evening,
Yeah,
sir.
yeah. Okay. Just a minute. Yeah. So cervical priming. Now we are discussing about the cervical priming. Remember, up till now we have not discussed about the priming. We have discussed about the therapeutic doses for abortion. Now we are talking about priming. The doses are different. So when you read the question carefully. What has been asked? Whether it is a therapeutic dose to carry out the abortion has been asked, or whether they are asking about the dose for the priming. Okay, so because priming we do in the first trimester also, priming we do in the second trimester also. So what is the drug which is used and what is the dose for therapeutic abortion and for priming? Now consider the cervical priming for surgical abortion. Now you are carrying about surgical abortion before 13.6 weeks of gestation. Offer cervical priming with 400 micrograms of misoprostol sublingually 1 hour before the procedure, or 400 micrograms of misoprostol vaginally 3 hours. So if you are giving per vaginal, give 3 hours prior. Dose is 400. If you are giving sublingually give 400, 1 hour is sufficient. Okay. Then if misoprostol is not suitable, consider 200 milligrams of mifepristone, but give 24 to 48 hours before. Okay. So if the mifepristone used for cervical priming, then you have to give 24 to 48 hours prior, before 13 weeks of gestation. And if you are using misoprostol, then dose is 400 microgram. And the further timing will depend upon whether it is vaginal or sublingual. If it is sublingual, it will act early, so give 1 hour prior. If it is vaginal, then give 3 hours prior. Okay. The priming reduces the risk of incomplete abortion, especially in Paris women. Eases dilatation in Paris and nulliparous women, may cause bleeding and pain-free procedure. Okay. Now here, I think the table, whether it is readable or not, but this is also frequently asked between 14 to 16 weeks of gestation. So offer cervical priming. Now we are dealing with 14 to 23.6 weeks of gestation. Offer cervical priming for all women. Insert osmotic dilators the day before surgical abortion between 14 to 23.6 weeks of gestation. If used for cervical priming, do not use misoprostol if osmotic dilators were inserted the previous day. Okay. Now here they are asking about the gestational age and the drug which is used for the cervical priming. Now here, how you remember this? So just divide it into two: 14 to 16 weeks of gestation, then 16 to 18 weeks of gestation, and 19 weeks of gestation, and from there onwards till 23.6 weeks of gestation. So here it is between 14 to 16 weeks of gestation, all three are available. That is OD, MF, and MI. That is osmotic dilators, mifepristone, and misoprostol. All three can be given. Okay, but after 16 weeks of gestation, I do not know, but meso cannot be used. Okay, so what you can, mife cannot be used. So osmotic dilators and misoprostol, only two are available. Okay, between 16 to 19 weeks of gestation, osmotic dilators and misoprostol can be used. Okay, and from 19 weeks of gestation to 23 weeks of gestation, offer osmotic dilators. Okay, consider adding 200 milligrams of mifepristone a day before. Okay, so you can use osmotic dilators. So main here is a osmotic dilator. So after 19 weeks of gestation, priming is by osmotic dilators. Along with that, you can add mifepristone, but it has to be a day prior. Okay, so this is what is the, so between 14 to 16 weeks of gestation, all three: OD, MF, MI. Okay, then you have OD and MI. Okay, then you only have OD after the, OD means osmotic dilators. Okay. So improving access to contraception, abortion, generally here I am not sure. They can ask you about the timing. So when will you use the contraceptive, when you will give the contraceptive implant, etc. So contraceptive implant should be offered on the day of surgical abortion. So if you are caring about the surgical abortion, you can use the implant at the same time. If you are when mifepristone is taken for medical abortion, intrauterine methods should be offered during surgical abortion and soon after the expulsion of medical abortion. So IUD, when will you offer IUD? If you are during the surgical abortion, or if you are giving the medical abortion after the expulsion, you will give intrauterine methods. Okay, and if the patient uses DMPA, when will you give DMPA? At the time of mifepristone, you will give and explain slightly increased risk of ongoing pregnancy. So they may ask you about the timing for implant at the time of surgical abortion. Okay, or if you are giving mifepristone, if she is for medical methods, then when you are giving the mifepristone, at that time you will give the implant, not at the time of misoprostol. Okay, is it clear? Implant one, if it is a surgical abortion, on the same day. If it is a medical abortion, along with mifepristone, you can give implant. If it is an intrauterine method, then again along with the surgical abortion. And if it is a medical, then after the expulsion, obviously you cannot, it's not like an implant, so you have to give intrauterine device only after the expulsion. And DMPA along with the mifepristone, but there is a slightly increased risk of ongoing pregnancy. Okay, So follow-up after medical abortion, offer self-assessment, etc., etc. And here low sensitivity or multi-level pregnancy test to rule out pregnancy. Home expulsion safety timing. This is not asked, so I will not go into the detail. Abortion after 13.6 weeks of gestation. Only how many percent? 0.1% of abortions are carried out after 23.6 weeks of gestation, and the commonest indication is a fetal anomaly. So after 23.6 weeks of gestation, the only 0.1% abortions are carried out, and the commonest indication is a fetal anomaly to save the woman's life and to prevent the grave physical or mental injury to the mother. So that finishes the abortion NICE guideline. Okay. Now here only small articles are there that will just quickly finish in next 10 minutes. Then we'll go for master class. Okay. MVA out. It's an outpatient alternative for surgical management of miscarriage. Okay. There are few SBAs in here in this particular as talk. Okay. MVA syringe is made up of latex-free plastic. So here it is one of the SBA. What is the makeup of this MVA syringe? It is the latex-free plastic. Okay, and it comes in a single wall or double wall forms. Double wall syringes are more often used, and capacity is around 60 ml. Vacuum 610 to 660 millimeters. Please remember these figures. They can be asked. The size of the cannula is 24 centimeter long, and their number is from 4 millimeter to 12 millimeter. Okay, there are marking dots from the 6 centimeter from the tip. Okay, placed at 1 centimeter apart. This is just the brief description, but these particular figures you just remember: capacity 60 ml, vacuum of 610 to 660. Okay, 24 centimeter cannula size, latex free plastics. So these particular things are can be asked. Okay, then procedure we know well. There is no question which is asked here. Okay, once the syringe is 80% full, detach and empty into the bowel. This all we know. We are carrying out this routinely, so I will not go into details. This is an OPD procedure. Okay. To ensure careful selection criteria, low risk. So for which patients this MVA is suitable? The patient should be hemodynamically stable, parous women, well-motivated multiparous, and well-motivated nulliparous women who can tolerate. So mainly it is for parous women, but well-motivated nulliparous women can also be used. Then speculum examination, ultrasound diagnosis of early fetal demise with CRL less than 25 millimeter. Remember, if there is a fetal demise but CR is less than 25 millimeter, you can go ahead with the MVA. Ultrasound diagnosis of incomplete miscarriage with written products of conception, but it should be less than 5 millimeter. Okay, so these particular things are very, very important in selecting. Okay, no clinical signs of infection, fever, offensive discharge, etc. So there should not be any infection. Women who are not suitable for outpatient MVA include more than 10 weeks of gestation, panic attacks, cervical stenosis, fibroid uterus more than 12 weeks, uterine malformations, hemorrhagic disorder at treatment and on anticoagulant, then allergy or contraindication to the use of misoprostol, then postnatal written products, uterine infection, inability to tolerate pelvic examination, and written products more than 5 centimeter. These are the contraindications for MVA. Okay. Complications during MVA include uterine and cervical injury, pelvic infection, incomplete evacuation, perforation, pain, vasovagal collapse, etc. And this is very cost effective. So these figures are not asked, so I will skip this. Okay, only thing is that just remember that it is cost effective. Okay, pain management is crucial for successful outpatient MVA. Pain levels vary among women due to anxiety, cervical dilatation, and uterine manipulation. Use pre and post procedure analgesia and adequate local anesthesia. Nitrous oxide can help women with severe pain during the procedure. Anxiety greatly affects the pain perception. A calm and supportive environment helps to reduce the discomfort. Okay. Paracervical block does not fully cover uterine fundus. Remember, the uterine fundus supply is this is part 1. You remember this T10 to L1. Okay, that is why the fundal pain generally not covered by the paracervical block. So you may have to give additionally 400 to 800 micrograms of ibuprofen or naproxen 500 milligram given 30 to 60 minutes before the procedure. That will help. Okay, so that finishes this particular thing. Small talk on MBA. So very few things in this particular talk we have seen, and this is the last topic of today, that is SIP, that is scientific impact paper, that is best practice in abortion care. Only few slides are there. In 5 minutes I think we should be able to finish, then we'll go for masterpiece. So what we have seen is a medical abortion which uses the medication to end a pregnancy, and most commonly used medications are misoprostol alone or misoprostol in combination with mifepristone. Surgical abortion, the use of transcervical procedure to end the pregnancy, ending into either MVA or EVA, that is electrical vacuum aspiration or dilatation and evacuation. All aspects of abortion care should be delivered in a respectful and sensitive manner that is person-centered and recognizes women and pregnant people as a decision maker. Okay, so I don't think here there are any SBAs or EMQs. Yes, these charts sometimes there can be asked, but I think somehow this has not become readable. I'll upload a very good in PDF there. Here, no, this is not for part 2, part 3, but this is important. Okay, yeah, this particular we can enlarge this. I do not know. Here there are few figures which are important. I will upload this. Not much important here. Prophylactic antibiotics are not needed for medical abortion. They should be given for surgical abortion to reduce infection risk. Lack of antibiotics should not delay surgical abortion. Effective antibiotics include metronidazole, doxycycline, and penicillin. This is about the scientific impact paper. What we have seen NICE guideline is doxycycline 100 milligram BD for 3 days only. But if you see the SIP mentions doxycycline 100 milligram orally BD for 3 to 7 days. But as per the NICE guideline, it is only 3 days, because even if you read this SIP, they mention 3-day course is as effective as 7 days. Okay, so doxy 100 milligram BD for 3 days, and you have to start within 2 hours of the procedure. Okay. So this is about the contraception. All contraceptives can be used along with it, and that finishes today's topic of this SIP abortion care also.